You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for April 19th, 2024. This week, I'll do a second ACC recap. We'll do the TACT trial of chelation therapy. We'll do Relieve HF, which is Interatrial Shunts for heart failure. We'll do a couple triglyceride lowering trials and an interesting trial on Diltiazem and Factor Xa anticoagulants. First, TACT. Let's start with a trial that teaches a vital lesson in critical appraisal and scientific skepticism. I lead with this trial for an important reason. TACT studied chelation of heavy metals as a treatment for atherosclerotic vascular disease in patients who had diabetes. Chelation, I know, it's not standard medicine, it's alternative medicine. But hear me out on this one. Back in 2013, Dr. Gervasio Lamas, an established cardiac researcher, announced and published in JAMA the results of the TACT trial. That trial stunned the cardiology community. TACT was a double-blind, placebo-controlled trial of 1,700 patients who had had previous myocardial infarction. Patients were randomized in a 2x2 design to receive 40 infusions of chelation solution or placebo solution, as well as oral vitamin regimens or placebo. The primary endpoint of a composite of death, MI, stroke, coronary revascularization, or hospitalization for angina occurred in 26% of the chelation group versus 30% of the placebo group. That hazard ratio was 0.82. The confidence intervals went from 0.69 to 0.99, and boom, it was a positive trial. In a subgroup analysis of TACT, they subsequently published this separately in Circ Outcomes, and I'll link to that, in patients with diabetes. They also found here that they had a larger reduction in the composite endpoint, including even a death reduction. The hazard ratio in patients with diabetes was a whopping 0.59, and the confidence intervals went from 0.44 to 0.79 over a 5-year period. Now, because this was one of many subgroups that they analyzed, the authors did a Bonferroni adjustment, and it still remained positive. The absolute risk reduction was also very impressive at 13%. That's an NNT of 6.5. No effective chelation was seen in non-diabetes patients. At the time of TACT, this created a huge stir. JAMA editors wrote an explanatory letter. JAMA also published a Steve Nissen editorial expressing great doubt. The big arguments against TACT at the time were A, there were no obvious reasons that chelation could work. Lots of patients were recruited at chelation centers, and chelators were not standard doctors. Now, I can't recall exactly what Dr. Lamas told me back then, but it was something like, I'm not sure, but this is a really important signal. Not only might chelation be an important way to treat vascular disease, but it could also implicate a new causal mechanism of atherosclerosis, that is, heavy metals. So, Lamas did science the way it is supposed to work. He sought to confirm this data in another trial. The TACT trial received NIH funding, and this targeted the subgroups of diabetes patients which had the largest signal of benefit in TACT. This was obviously a massive effort, and Lamas presented TACT at ACC. 1,000 patients who had had an MI and diabetes, chelation versus placebo with vitamins versus placebo, same plan, same MACE endpoint. He added a metals level endpoint as well, and After 2.5 years, there was no significant effect of chelation hazard ratio, 0.93, confidence interval 0.76 to 1.16. There was no difference in death and no subgroup signals. The EDTA chelation lowered blood lead levels by about 60%. Now, Lamas offered a slide with a possible explanation, and that is that lead levels have declined. In an NHANE study, he showed that lead levels were 17 micrograms per liter back in the early 2000s, but now levels are about 11 micrograms per liter. Now, this, of course, is a plausible explanation. We've seen it with beta blockers after MI. We've seen it with ICDs in heart failure. As the disease changes for the better, so does the treatment effect. Now, I would offer an alternative explanation, one that I think is as important as any concept I have discussed on this podcast. My explanation centers on a paper by Dr. Eric Van Sweat, published in New England Journal of Medicine Evidence a few months ago. Van Sweat is a statistics professor in Leiden in the Netherlands. He and a bunch of other statisticians analyzed, and sit down for this, 23,000 RCTs in the Cochrane database. They were interested in studying A, the degree of overestimation in trials, B, the probability that the estimated effect is in the same direction of the true effect, and C, the predictive power of a trial to replicate with another significant p-value of less than 0.05. Now, they did a fairly complicated analysis looking at the Z statistics of the trials and their signal-to-noise ratio. And I won't get into the details, mainly because it's difficult for me to explain and even understand, though I will link to this interesting paper. But they found that most trials have extremely low power, like below 25%. Most trials overestimate the confidence in the results, and even highly significant trials have a low probability of replicating as another significant trial. Get this, the first sentence in their discussion reads that the initial p-value between 0.001 and 0.005 in a trial implies only a 58% chance of getting a p of 0.05 upon attempted replication. And it's even more unreliable in the stratum of p-values that we usually see around 0.01 to 0.05. That chance of replicating as a significant trial is only 37%. My thesis, therefore, is that the original TACT trial produced a positive result that was likely spurious. And this notion, I think, is so important for us who interpret trials. We hear so often about positive trials that have a p-value around the level of significance, and we're told, hey, these trials are positive. But this analysis suggests that a single trial usually has a low power, and even when significant, or gulp 0.06, we should have a lot less confidence than we do. I use the example of Paragon HF of sacubitril valsartan versus valsartan and HFpEF. This comes to mind. Here, the 13% reduction in CV death or heart failure hospitalizations came with a confidence interval of 0.75 to 1.01 and a p-value of 0.06. Well, at FDA, there were many different analyses presented in women, in those with heart failure with a slightly reduced EF, as well as analyses that separated investigator-reported events versus clinical event committee adjudicated events. But every time we see a study like this, with a broad confidence interval, with a marginal p-value like in TACT-1, we should remember the lesson of the TACT-2 trial, that is, that most trials are underpowered. Many effect size estimates are overestimates, and if replication trials were the norm, many of these results would not replicate. Not because of shenanigans, but because trials necessarily recruit the smallest number of patients necessary and are often underpowered to sort signal from noise. Hence, be skeptical and conservative in what you accept as beneficial. All right, next topic, interatrial shunts for heart failure, the RELIEVE HF trial. In heart failure, dyspnea due to pulmonary vascular congestion occurs because left atrial pressure is high. The idea is thus: we can place an interatrial shunt to shunt blood from the high pressure LA to the lower pressure RA, and if this was a Goldilocks-like shunt, that is, just the right amount of offloading of LA volume and pressure, but not so much to overload the RV, then you might be able to non-pharmacologically relieve congestion and modify heart failure outcomes. A company called V-Wave has a shunt and in smaller studies has been shown to reduce filling pressures and provide symptom relief in patients with both HFrEF and HFpEF. Now recall that another company's atrial shunt had failed to improve outcomes in a sham-controlled trial called REDUCE-LAP-HF2 trial. In Lancet 2022, I'll link to it, that atrial shunt device failed to reduce heart failure events or improve quality of life in patients with heart failure and an EF greater than 40%. Relieve-HF, however, recruited patients with any kind of heart failure, and this was a proper sham-controlled trial. They did a placebo procedure like we always should. The primary efficacy endpoint was a composite of death, LVAD or transplant, all heart failure hospitalizations, outpatient worsening heart failure events, and a change in quality of life measured by the KCCQ. And they analyzed it with a win ratio, which counts death and heart failure events as more important than quality of life. There was also a safety endpoint, as appropriate because putting a foreign body in the LA and RA is no small thing. They recruited about 250 patients in each arm, shunt versus placebo procedure. And the safety endpoints ended up being great. 0% of the shunt arm had a safety issue in the month after the procedure. But the efficacy endpoint, even considering the sort of soft win ratio of multiple outcomes, was not significant. Not significant. Win ratio equals 0.89. The hazard ratio went from 0.72 to 1.09. A secondary endpoint of cardiac events minus the KCCQ endpoint was also null with a hazard ratio of 1.00. The Kaplan-Meier curves looked identical. Total deaths was 15.7% in the shunt arm versus 13.7% in the placebo arm. There were wide confidence intervals for this 31% higher rate of death, so we can't conclude anything about it, but still. The KCCQ, the quality of life change, also totally the same. Though I really want you to look at this slide. Interesting was that both groups bumped 10 points immediately after either procedure. That was either after the placebo or the actual shunt procedure. This indicates in super clear terms the need for a placebo procedure. Yes, I am talking to you, Triluminate trialist. But this is not the end of the story. Oh, no, it is not. Dr. Greg Stone did not disappoint at ACC. In the next slides, he presented the subgroup analysis dichotomizing by left ventricular ejection fraction less than 40% or greater than 40%, and this was a whopper. About 40% of enrolled patients had a reduced LVEF, and 60% had an LVEF greater than 40%. Okay, here it is. In patients with low EF, less than 40%, the shunt reduced the secondary composite of death, LVAD, all heart failure events, and outpatient heart failure events by 45%. Hazard ratio 0.55, confidence interval 0.42 to 0.73. But, a double but, in patients with a left ventricular ejection fraction greater than 40%, it was like a mirror image. Patients in the shunt arm had a 68% higher rate of that secondary composite heart failure endpoint. Here the hazard ratio was 1.68, 68% higher, confidence intervals 1.3 to 2.2, and both p-values here were highly significant. All of the components of the endpoint went in this direction. The shunt was better in low ejection fraction patients and harmful in those with EF better than 40%. Here's the thing, though. KCCQ endpoint measuring change in quality of life was exactly the same in either EF subgroup. So my comments. Wow. As a student of heterogeneous treatment effects, I am intrigued. There is not yet a paper on this, just slides in a presentation. But what should we think about this? On the one hand, the overall trial results are null, even using the win ratio. Trials are powered for overall results, so those should get the most weight. Plus, as priors, we ought to be pessimistic, right? Because A, we have super good therapies for heart failure already. B, a foreign body is unlikely to work. See also the negative PREVAIL trial of Watchman. And C, the reduced lap HF2 trial of a similar atrial shunt device had already failed. So if you combine these negative priors with a null result, the likelihood is we should not be too excited about this strategy. But on the other hand, the dramatic subgroup finding of benefit in HFrEF and harm in HFpEF has two possible plausible explanations. First, physiologically, it is possible that patients with HFpEF, who often have coexisting pulmonary hypertension, are more sensitive to higher flow in the RA and RV. The second reason for plausibility just comes in the statistics, right? If the effect size of the main trial is null, and you posit benefit in one large subgroup, you ought to have harm in another subgroup. And here we have 40% of the trial population getting a benefit and 60% getting a harm, so that sort of fits with a null trial. Now, you all know what the next step is. It is not approve the device for patients with HFrEF. It is do another study of just patients with HFrEF who look like patients with HFrEF in the original RELIEVE HF trial. Now, remember what I just said about significant p-values. There is still a chance that this will not replicate, and that left atrial appendage story of widespread acceptance of a foreign body in the heart, despite a negative regulatory trial PREVAIL, should teach us a lesson about proving efficacy before approval. I say congratulations to Dr. Greg Stone and his colleagues, and I look forward to the RELIEVE HF2 trial of the Interatrial Shunt in patients with heart failure due to a reduced ejection fraction only. All right, next topic, triglyceride lowering. At ECC, during a late breaker, we heard results of a phase 2 trial looking at a drug to reduce triglycerides. The drug is called Olezarsen. It's hard to pronounce. It is an antisense oligonucleotide targeting messenger RNA for apolipoprotein C3, the ApoC3 complex. Now, all I will tell you is that this drug worked. It lowered triglyceride levels. The study made it in the New England Journal of Medicine with 154 patients. There was a dose-response relationship as well, and there were no adverse effects. Sounds great, right? Well, not so much. This is mile 2 of a marathon. A drug that lowers a lipid level is not enough in this era. You need a big outcomes trial that shows it reduces cardiac events on top of standard statin therapy. Statins reduce cardiac outcomes by 20 to 25%. They cost pennies. That's a very high bar. In fact, all lipid-lowering therapies that are new have a high bar. What's more, I have grown increasingly suspect of phase 2 trials. Recall that phase 2 trials are usually dose-finding studies. What clinicians mostly deal with are big phase 3 clinical trials that test clinical outcomes. The reason I have become increasingly worried about hype surrounding phase 2 trials is the factor 11 anticoagulant asundexian story. Here, multiple phase 2 trials came out showing less bleeding. Everyone was talking about factor 11 inhibitors, the ideal anticoagulant I heard from the KOLs. And we were recruiting patients for the Oceanic AF phase 3 clinical trial, and we were doing it with great success because it was asundexian versus apixaban, and it was a great way for people to get free anticoagulation. Then, boom. In less than a year, the trial was stopped due to inefficacy of stroke prevention. So, please, let's put these phase 2 trials in poster form and let them be on the big stage when the phase 3 study shows that they actually help people. And, by the way, there was another phase 2 trial, a late breaker on a triglyceride-lowering agent called Plozasiran. This was an investigational ApoC3 targeted small interfering RNA drug, and it too lowered triglyceride levels. The Shasta-2 trial had about 230 patients, and it included patients with severely high triglyceride levels. And like the previous drug, this drug worked to lower triglyceride levels. Great. Now, let's see how miles 3 through 26 with these drugs go. All right, next topic is Diltiazem and direct-acting oral anticoagulants. This is one non-ACC study that really caught my attention this week. If you care for AFib patients, an observational study in JAMA deserves your attention. But first, some background. It's an everyday thing. A patient with AFib who is taking apixaban or rivaroxaban is prescribed diltiazem for rate control. It's as normal as rain in Kentucky. No one even notices. Now, another normality in my world of private practice. You almost never hear a clinician speak about drug metabolism or pharmacology. Yet, I'm sure most listeners have something stored in their brains way back there, the basic fact that plasma levels of the factor Xa inhibitors, apixaban and rivaroxaban, are influenced by hepatic cytochrome P450 3A4 CYP3A4 enzymes. These enzymes promote metabolism and then elimination of the drugs. Another fact probably stored in your brain, perhaps from training many years ago, is that the calcium channel blocker diltiazem is a strong inhibitor of CYP3A4, which means it can produce up to 4x increases in the plasma concentration of drugs metabolized by CYP3A4. Diltiazem also weakly inhibits the P-glycoprotein-mediated metabolism. Thus, co-administration of diltiazem with apixaban or rivaroxaban increases the AUC by about 40%. Since bleeding rates from these anticoagulants correlate with plasma levels, you can see the problem. Diltiazem and Factor Xa inhibitors could increase bleeding. Guidelines, it turns out, are good about telling us to use expensive devices and drugs, but they're not so specific about drug-drug interactions. They say clinicians should, quote, consider drug-drug interactions, but do not mention any specific interactions. Okay, a Vanderbilt University-led team, first author Wayne Ray, performed a retrospective cohort study using Medicare data. JAMA published a study which included more than 204,000 AF patients taking either rivaroxaban or apixaban, in which a quarter of these patients, about 53,000, received diltiazem, and three-quarters, 150,000, received metoprolol. The primary endpoint of their study was a composite of bleeding-related hospitalization and death with evidence of bleeding. In essence, this was a non-random comparison study. Bleeding rates with the two rate-controlling meds. One medicine was diltiazem. It raises DOAC levels. The other medicine, metoprolol, does not affect DOAC levels. The main result was that, yes, patients taking diltiazem along with their DOAC had an increased rate of the bleeding primary outcome. The risk difference was about 10 per 1,000 patient years. The hazard ratio, 1.21, so a 22% increase. A couple other important findings. They also found a dose-response association. The risk for the bleeding primary outcome was higher when diltiazem doses exceeded 120 milligrams per day compared with lower doses. Here, the risk difference was 15 per 1,000 patient years versus 7 per 1,000 patient years in the lower dose group. Another important finding, there were no significant differences in the risk for ischemic stroke. Thrombotic events did not seem to trend the same way that bleeding did. Okay, comments. Higher bleeding rates with co-administration of diltiazem and Factor Xa inhibitors is an important observation. It's very common. The authors list many previous papers that have looked into this relationship. Most of these papers find an increased bleeding risk, but some do not. However, most of these previous studies were smaller or had less robust methodology. The RCTs of these drugs had many fewer patients. For instance, I went back and looked at Aristotle, apixaban versus warfarin. There were about 2,700 patients in each arm who took diltiazem, and I think it's pretty hard to sort out much of a signal there. Plus, remember, trials enroll ideal patients. So, large database studies like this have both big numbers and they enroll real-world representative patients. That's a strength. There's also a plausible pharmacologic reason for the increased bleeding signal when the drugs are co-prescribed. And regular listeners know that I always speak of the possibility of confounding variables and selection bias in studies when a clinician chooses one or the other treatments rather than randomization. And that is also a possibility here. Maybe there was something about diltiazem-treated patients that made them more susceptible to bleeding, and it wasn't just this association. But I've been racking my brain trying to think of a confounding factor that could cause diltiazem-treated patients to have a higher risk of bleeding versus metoprolol-treated patients. And I can't seem to think of one. Maybe you can. Let me know. For instance, in many of these types of non-random comparison studies, sicker patients get one treatment. The classic example is digoxin, and that is why they get worse. But here, the choice of metoprolol versus diltiazem, I think, is largely just a habit. Some doctors use DILT and some use beta blockers. What's more, the authors did sensitivity analysis, which helped to exclude some confounding. Thus, I think this finding is real. I am a pharmacologic worrywart. I think about drug-drug interactions and CYP3A4 and P-glycoprotein a bunch. The problem, of course, is that I am also increasingly negative on beta blocker therapy for many indications, such as post-MI and perhaps in HFpEF. I've been increasingly using non-beta blocker means to control AFib rate. But this study should make us think about bleeding rates with co-administration of diltiazem and factor Xa inhibitors. And we're never going to get this sort of data from clinical trials. It's just not enough patients and not enough real-world experience. Yet, we should also be clear about this paper. These are small differences. The relative risk of increased bleeding was about 20% higher, but the absolute risk increase was in the range of only 1%. So we don't have to be paralyzed in our decisions. But if you have a patient who's high bleeding risk, we might choose a beta blocker or gulp even digoxin for rate control. Obviously, most of the time I look at these observational non-random comparisons and think that there's just a high possibility of confounding and don't think much of them. But in this case, I think it's a little different, but maybe you disagree, so please do let me know. Finally, I was going to do the SMART trial of self-expanding TAVI valve versus balloon-expanding TAVI valve in patients with AS and a small annuli. I was also going to do the Orbit, a cosmic trial of the coronary sinus reducer, but A, I have gone on long enough, and B, a monster thunderstorm rolled through Kentucky last night and took out our power. So this morning, I am technically challenged, and also remember, home espresso machines require electrical power, and so I'm going to get to those studies next week. And if anyone has ideas on how the SMART trialists justified using non-inferiority and a hazard ratio margin of 1.5 in a test of 2 TAVI valves, please email or tweet at me before I do the podcast next week. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, friends, if you like this podcast, it really does help to take the time to give us a rating on whatever podcast app you use. Write us a brief sentence or two, and if you disagree with something I say, go to the website, write a comment. I learn a lot from these. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.